You can see the patient has been wearing a really poor denture, and he has about maybe 3 teeth left on the top, and the lower is edentulous. And when you think about it, it's probably a very straightforward case. But as with every single case, we do a full workup on the patient. The patient had 6 stents, was on Plavix, was on multiple medications, and he wanted to have this done ASAP. In general, although his medical history was pretty much in a very good spot, we got medical clearance from the cardiologist. We stopped the Plavix. And you'll see throughout the surgery how we manage these type of cases when the patient is medically compromised, whether he also has some diabetic issues that we manage during his anesthesia. But you can see how we do these cases quickly and at low risk for the patient. So we'll start the video. And we go ahead and we're going to start the lower first because we had planned a little more extensive surgery. So we're going to go ahead and use this electrosurge to minimize the amount of bleeding that he's going to have. We open a very minimal flap, and we do everything in quadrants. So we make sure he's very numb, and then we go ahead and we take off the peak of bone where he had that resorption to give me a nice flat plane. Although he had good depth, his width wasn't great. And we go ahead, we pick the first molar position. That's our first osteotomy that we go ahead down to depth. And then we find the mental nerve and we go forward from there, and that's our premolar position, and then we go 2 steps forward from there, and that is our new lateral position. Now we have everything exactly where it needs to be, and we follow through with drill-specific, length-specific drills so that we can go as fast as we possibly can. You can see there's little to no bleeding. And depending on the density of the bone, sometimes we drill halfway so that there's not a lot of cortical spot. This is a Syn 360 Epicut implant. It can go in really, really quickly, so you got to be careful. And we place these about 1 millimeter subcrestal. A lot of irrigation. You can see it got stopped about 75% of the way, and then we go down to 1 millimeter subcrestal. This is a 3.5, and then we're going to go ahead and drop it about 1 millimeter subcrestal. And then we go ahead and place our multi-unit abutments, about 30 Newton centimeters of torque. These are all about, I think, 1.5 millimeters. And now we want to make sure that everything is released correctly or the periosteum is removed. And now we start to suture everything back together. We reposition the tissue, buccally, and then we go ahead and place the fluorochromic suture, and we do everything in small little spots with a continuous. You can see we're suturing everything nicely. And now we felt that the bone over there was a little bit too thin, possibly to have some resorption, so we want to build the thickness of the tissue with my Ogma tissue protocol. We add some Ogma down in there to create some space for the tissue phenotype to change. We continue to suture it. Again, remember, this patient's on Plavix. He stopped that about 4 to 5 days ago. He's now on aspirin so that we make sure he doesn't get any clots during surgery around his 6 stents. And now we go ahead and replace the THS caps. And again, you can see it's a very, very clean surgery. You can even look around. You can see his mouth is not covered in blood or anything like that, because we're really working on trying to control this. And we're also checking his sugar intraoperatively. And you can see in this case, his sugar spiked. So my anesthesiologist was a star. He hydrated him tremendously to dilute that, and we got his sugar back under control, so we didn't have to abort the case mid-op. Close everything, and then about here you'll see I add another THS cap to hold the tissue down, and now that side is done. We're moving to the other side. I guess it was cut a little bit, but we do the exact same thing. Electrosurge, place the implants, molar, front of this mental foramen, and 2 teeth on top of that. Suture everything the way it's supposed to be. Bulk up the tissue if we need to. You can see how it's held up really nicely with the suture, and then the THS cap will keep it in spot. Clean everything up, and now the lower is completed. There's no blood, and you can see how easy it would be to scan this. We powder it because you can see how shiny it is, and we don't want to have poor scanning. So we go ahead and we scan, come all the way around, take off everything, put in the True Abutment IO Connect. We scan that, and now we're ready to go to the top. Take out the teeth atraumatically. Again, we do everything in quadrants, slowly, slowly, slowly. This case was actually planned for a zygoma on the upper left side, so I was leaving that to the left, to the last, so that we wouldn't have oozing or anything like that. Electrosurge all the way across. Come around the incisive nerve. Make my little H incision, and that's going to be the posterior portion of my first osteotomy. In this case, we're going to go ahead and angle it to avoid the sinus as much as we can. And then we saw, based on where the sinus was, that we would come out exactly in where the first molar would be, so no need to do any of that. A little bit of infection around there. We're going to clean everything up. Clean up the bone just a little bit to get the ramp away. Not for prosthetic space or anything like that, but just enough so that we have a flat surface so that when the prosthesis is made, it's easy to clean and there's not a roller coaster of up and down. And we start with our first 30-degree placement. Go straight on that one, right by the premolar, and then boom, right down in there. Again, all this is studied before, so you can see I'm just drilling really quickly, increasing the density with some densiburs, going to depth, same thing there. Again, all in reverse at 1200 RPM. Again, very minimal bone. Patient is not intubated, he's breathing on his own. He has anesthesia on board, but those are Megagen implants, going straight in nicely. Great, beautiful torque. Again, this one is nice and straight. Straight in multi-unit abutment. Same thing on that one, nice and straight. And then on this one we have to go to 30 degrees, and because of the way that the abutment is designed, it's a little bit hard, so we have to start playing with the bone. It's one of the things I don't like about the system. But then we're going to fill in the bone grafting areas, and we're going to reapproximate everything back together. And we start suturing everything. We don't cut the tissue because I love that tissue. That's what protects my implants in the future. So we just reposition it if we need to. And we continue. If you're a dentist watching this, make sure that you always protect your tissue. Your tissue is everything. If you're a patient, it may look gory, but this is what it takes to be able to make sure that you have the tissue where you want it so that your gum looks good. And even if you have a little bit of extra, we just rotate it over where the socket was. And then we use the THS caps, part of my inventions, to hold everything together exactly where it needs to be. So look how nice the tissue on the buckle is going to be when everything heals nicely. Suture, there's no bone suturing or any of that nonsense that people like to do. It's just not needed. Don't make extra holes in your patient's jaw just for fun. Learn how to stitch, learn how to manipulate tissue, and use the right parts to be able to hold everything together. So take a look at this. That's the beautiful thing about the THS caps. No blood. And remember, this patient has been on Plavix, and he's on aspirin now. So minimal blood. And now we make the decision, are we going to go to zygoma or not? So after we take out the tooth, we go ahead and we make our incision, same way, decide where the molar is going to be based on our original wax up, make our little H incision, protect the nerve. Whether you need it or not does not matter, but we go ahead and we check to see, do you need to go up to the zygoma or not? Or can you play with angles and multi-unit abutments to avoid having the patient go through a more traumatic surgery? I know some people want to do zygos so that they can feel great, but sometimes you can graft, sometimes you can angle, and sometimes it's a little bit better for the patient to not have to do that. Now, there's no bone, we open it all the way, and we do zygoma, no big deal. But in this case, you can see, based on where the position of the sinus was, I was able to get around it and avoid the zygomatic implant. You'll see at the end of the video the x-ray of the case. Again, let's clean up some of the granulation tissue, some of the areas that are not even, so that we can make everything nice and flat. And then I go as posterior as I possibly can. Remember, I'm keeping the last implant for the last to decide if I'm going to go zygo or not. But osseodensification, you can see in this the maxilla is actually pretty angled, so you can see that the way that I'm drilling is a little bit angled, so you'll see the choice of the multi-unit. I can feel this right away, and I know when I'm drilling that what multi-unit's going to go based on how the position of the bone was and is. Again, these are Megagen AnyRidge implants for the top. In this case, we did 17 degrees. And now we drill and see how far we can go. You would think I'm hitting the implant, but you'll see in the x-ray I'm not. I check to make sure that I'm not in the sinus, which I'm not, and if I am, I'm going to reverse, so I'm lifting it at the same time. It's one of my little tricks. Okay, perfect. And then we go ahead and we place that implant at a probably 30-degree angle. Also excellent torque. We go a little bit deeper because we know the multi-unit is about 3 millimeters tall, so we don't want it to be flying up in the air. So we need to do, again, struggling with the Megagen. And then I realized that the position of the implant is a little bit wrong, so I'm going to reposition that so that my multi-unit comes out where I want. You could always use a non-engaging one, but not my favorite. Once we reposition the implant hex, we fill some bone in wherever areas we feel like we need some adhesion and some fill, and then we go ahead and we suture. Again, look at the patient's lips. Look how clean it is. A lot of people post their cases and the patient it's full of blood, it's messy. You gotta be clean when you do surgery. You can't be a brute. You gotta be very, very gentle. You gotta protect the oral environment, and more importantly, protect your patient so that you have a nice recovery with minimal pain. Again, you could see I don't cut any of the tissue that's still there. I just hold it in with my THS, tuck it in where I need to, and reposition where I want the new thickness of the tissue to be. Again, no bone sutures. Nothing fancy, just interrupted interlocking. Again, another 2 millimeter THS. We'll close up some connectors here and there, or what we call some vertical releasings. Oh, I ripped it. Thin tissue. Let's try again. grab a little bit bigger, bite. Sometimes you don't have to grab all two at the same time, just grab one and then suture. And realize that that part was already cut out. So let's suture one more time. Third time's a charm. Bring everything as close as we can together without tension. And now we go ahead, scan the upper soft tissue, take it off, put the IO connects back in. As close as we can to each other without them touching each other. This is a 6-second scan maximum, nothing more than that. Take it off, put the soft tissue scans back on. And now the magic happens to make the patient's teeth. There's the Excel device. We know it's correct. We're going to loop that in place for our registration. And we're going to do the bottom with the right CR and vertical position. His nose was tricking me a little bit, but anyhow, we export everything, align everything together to make sure everything is done, triple check the IO Connect and the soft tissue as I showed in a previous video. You can see here how the soft tissue scan was off because of the Trios 5 algorithm, but we knew that the IO Connect was correct after we aligned it, and it matched with the temp scan, so we were ready to continue and not having to rescan. After we aligned everything together, go ahead and create our exocad project. Patient is slowly waking up as I'm doing this. I import all of the files that I just did. And super easy, you just select the THS caps, everything aligns perfectly at 100% alignment. That's for the upper. I'm going to go ahead and do the lower. Powerball screw 2.0. Emergence profiles. And now we check if we need to angle any screws. 5 or 6 degrees on some of them. Other than that, basically perfectly straight. We connect everything together. Time to smooth everything out. Control the tissue pressure as we want it. And then we're also going to add it to the Dentifab to print, because the last thing I want is a failed print. Anyhow, none of them failed. We colored it. We'll go ahead and Powerball screw them. Deliver everything together. And just so you know, I know everything is in fast motion, but this whole case takes about 3 hours from the time we get him numb to the time he walks out with his teeth. This is all 3 hours, not 6 hours or 8 hours like people are saying. This is a 3-hour process. So we save patients on pain. We shave. Look how great it looks already, the tissue. This is right then. Have the patient bite down. Everything is perfect. Clean up. And he is ready to go home. This is life-changing to be able to do this in 3 hours. I mean, give me a break. You're a patient, do this for yourself. Don't be a dentulist anymore. If you're a doctor, do it the right way. And if you can't, learn how to do it the right way, because you owe it to your patient. Subscribe below for some more videos. And more importantly, comments are always welcome. Have a great day.